my
Hello.
co-examiner.
Hello. Nice to meet you.
Now, you've got 2 patients to see in this station. Can I just check that you've got Jane Smith, who's your first patient?
Yes.
That's correct. So this is Mrs. Smith. So you've got 8 minutes to take your history and examine her and deal with her concerns, and we'll let you know when there's 2 minutes left.
Okay. Hello.
Hi.
Jane Smith. It's nice to meet you. My name's Dr. Mahendran. I'm the medical registrar on call. Do you mind if I ask you a few questions and examine you? Is that okay?
That's fine, yeah.
Can you tell me about this episode?
Well, it was around lunchtime and my eyesight just went, not completely, but just changed, and if I went like that, I just couldn't see anything out of my left eye, if I shut out the right. And it didn't last long though, about 5 minutes or so, and it came back.
Yeah.
But, I'm just worried, if it happens again or something.
I'm sure you must be worried. Has this ever happened before?
No.
And you said it lasted about 5 minutes, is that right?
Yes, yeah.
Okay. Before this happened, did you feel any sort of funny symptoms or see any funny things in your eyes?
No, I don't think so, no.
Did you have a headache at all?
No, I didn't have a headache, no.
Okay, good. Now, you're in hospital because of your diabetic ulcers, I think.
Yes, that's correct. Yeah.
Okay. Do you know what medications you're taking?
I'm on insulin, and
Mhm.
there's my medication
Okay.
chart.
Just going to have a look at your medication chart. Okay, so I see you're on insulin. You're also taking lisinopril and simvastatin. Okay. And your blood pressure has been okay,
Yes, yeah.
and I see that your sugars have been controlled.
Yes, they've been fine.
Okay. Now, do you mind if I examine you? Is that okay? First, I just want to see things. Do you need your glasses to read this?
Oh, no.
Okay. If you just cover up one eye for me, that's it. And if you could just read the first line there for me, just there.
Lloyd's dealt another
Okay,
blow.
that's very good. And if you can cover up the other eye and just read from another line, just read from there, please.
The banking group, 65%.
That's fine. Good. Okay. Just want you to look straight at here. Just look at my nose. And I want you to cover up your left eye for me now. Very good. And I just want you to tell me when you see the wiggling part of my finger, just keep looking straight at me. When you see the wiggling part of my finger, just let me know, okay?
Now.
Okay. Just going to do that again.
Now.
Okay, that's fine. And if you cover up the right eye.
Now.
That's fine. Okay. Just want to look at the back of your eyes. Would it be possible to dim the lights?
Yes, I'll just dim the lights for you.
Okay, I'd just like you to look straight ahead and just focus on a point there at the cross. Okay. Do you mind if I rest my hand on your forehead?
No.
Good, and look to the light. Okay, that's fine. Just look straight ahead again. That's it. Good, and look to the light. Okay, that's fine. Okay, thank you for that. Thank you. Okay, just going to listen to the vessels in your neck, okay? Just take a breath in and hold it. Okay, breathe away. And on the same side here, take a breath in and hold it. And breathe away. Okay. Your pulse seems to be irregular. Is that something that you've known about?
No.
Have you had any history of heart disease?
No.
And any history of palpitations or?
No.
Okay. I'd like to go on to examine her precordium and complete a full neurological examination.
That's not necessary, thank you.
Okay.
So you've got 2 minutes left with your patient now.
Okay. Do you have any idea what may have caused this?
No, I find it frightening. I mean,
Yeah.
will it happen again? Will I go blind?
I do understand why you find it frightening, but I am reassured by the fact that your vision has come back. But what I do think we need to do is to think about some investigations and also think about what treatments we can give you to try to stop this happening again. And that involves starting some treatments today.
So I'll be staying longer in hospital.
Well, I think that may not be completely necessary. I do think we need to think about starting on some aspirin. Have you had any problems with aspirin before?
No, just don't take it.
Okay, I think we'd need to start the aspirin today. We'd also need to do a recording of the heart, a scan of the heart and a scan of the vessels supplying the brain, and make sure that we're controlling your blood pressure as well as we should. I think the possibility is that when I've examined you, your heart is in irregular rhythm, and something may have gone from the heart to a vessel supplying the back of your eye. And we have to try to stop that happening again, and that's with the treatments. Okay, do you have any questions?
No, not really.
Okay.
So we'll have to stop you there.
Okay.
Can I ask you your clinical findings?
This lady has an irregular pulse with a rapid ventricular rate. She also has background retinopathy on fundoscopy examination. She has a background history of diabetes on insulin, and also she is on antihypertensives and anti-cholesterol tablets.
Right, so do you think is the most likely diagnosis?
I think she gives a history of amaurosis fugax, and I think in the context of atrial fibrillation that hasn't been previously known or treated, it may have been that she's had an embolic event from her heart that's gone to one of the vessels supplying her retina. She may also have carotid artery disease. She doesn't give a history of headache or any visual obscurations, so migraine seems less likely, and her sugars have been well controlled, so I didn't think it was hypoglycemia.
Okay, that's good. And what investigations would you consider?
I'd like to do a recording of her heart, a 12-lead ECG, and possibly a 24-hour tape. I also want to scan her an echocardiogram for her heart and carotid Dopplers with possibly a CT brain as well as that patient.
And you wanted to initiate some treatment today?
I think she'd benefit from starting aspirin today, and then as an outpatient we could discuss formal anticoagulation.
Okay, thank you.
I think we'll need to stop there and take you to your second patient. Have you got the history sheet for your second patient? Come this way.
Hello there, and you come, Dr. Pickford?
Yes.
I'm Dr. MacLeod, and this is Dr. Perry.
Hello.
Your first patient is Mr. Hamilton. He's your patient for today. We're taking you to the nervous system first. We'll give you 6 minutes to examine, 4 minutes for questions, and we'll give you a warning after 5 minutes.
Okay.
And the clinical scenario is on the wall.
Thank you.
Hello, Mr. Hamilton.
Hello.
My name's Dr. Pitford. Is it all right if I examine you?
Yes, of course.
Thank you. Before I start, have you got any pain anywhere at all?
No.
Okay, thank you. Could I ask you to walk over to that cupboard, turn around and come back, please? Thank you. Put back on the bed. Okay. Now I'm going to wiggle your legs around, so nice and relaxed. Okay. And now I'm going to be testing your strength, so I want you to lift this leg straight up off the bed, and then I'll resist you. So start with this one. As strong as you can. Excellent. And on this side. And push the backs of your knees down into the bed. And now bend your knees up. I want you to pull your heel up towards your bottom. And on this side. And push me away. And on this side. Okay, now lie your legs flat. If you could point your toes up towards your nose. As strong as you can. And on this side. And down to the floor. And down to the floor. And the same with your big toe. Down to the floor. And on this side. Excellent. And I'm going to test your reflexes. So again, really nice and relaxed and floppy. I'll take the weight of your leg. Just get you to clench your teeth for me. Just clench your teeth. Okay, all right, thank you. Just going to scratch the bottom of your feet. I'm going to test how much you can feel. So I'm going to just start by touching your chest and then down your legs. So if I could get you to close your eyes and say yes when you feel me touch you, and let me know if it feels particularly different anywhere.
Yes. 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 Yes, just.
Feel that?
No.
Okay.
Yes. Yes, just.
Does that feeling go away there?
Yeah, I can't feel
Okay. Right. You feel that?
that. No.
Okay. You can't feel any of this?
No.
Okay, all right, thank you. I'm going to do a similar thing with a blunt pin. Okay, so close your eyes. It should feel sharp, but it shouldn't hurt.
Yes. 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 Yes, well, it's not quite so sharp.
Okay,
Yes, a bit duller there.
okay. You feel that?
Just about, yeah. Yes, it was a bit duller.
Okay.
Yeah, just.
You feel that
Yeah,
at all?
just can feel that.
Okay. Okay, thank you. Now you can open your eyes. I want you to tell me if you feel this vibrating against you.
Yes. Just, I think. Really, no.
Okay. Can you feel any vibrations?
A little bit.
Okay.
You have 1 minute to complete your examination.
Okay.
Can't feel that. No.
Okay.
No, I can't get that.
Okay. And I'm going to move your toes up and down. I want you to close your eyes and tell me if you can feel me moving your toe up or down. I'll just tell you what I'm doing first. That's up and that's down.
Okay.
So what am I doing?
That was up, yeah. It's not very obvious.
Okay, we'll do the same on the other side. That's up and that's down.
That was up, I think.
Okay. Now could I get you to put the heel of your right foot on your left knee, run it down your shin.
Like that?
Yep. And then lift your heel back up in the air, onto your knee and down your shin. Excellent. And the same on the other side. Excellent. That's great. Thank you very much.
Thank you.
Okay, so this young Caucasian gentleman has signs of peripheral neuropathy. He has absent light touch sensation from the knee downwards and absent pinprick sensation from just below the knee downwards, and the same with vibration, and absent ankle reflexes. His gait and power are normal.
Right. Would a Romberg's have been helpful?
Yes, it would have been.
Okay. So what do you think the differential diagnosis is?
The most common cause of a peripheral neuropathy would be diabetes, but also alcohol, and maybe vitamin B12 and some drugs can cause that as well.
Okay. So what investigations would you organise for this gentleman?
I'd obviously want to do a full history and see if there was any history of diabetes and alcohol intake. And depending on whether he did or not have a history of diabetes, you might want to do a fasting glucose or a glucose tolerance test, and if he was diabetic, maybe an HbA1c. And I guess looking for alcohol consumption, that might have affected his liver function, maybe.
Okay. So what management would you be suggesting for this man?
So assuming he does have diabetes, the most important thing for him would be tight glycemic control. So ensuring that he has good education about his diabetes, that he's on the right medication, that he knows how to manage it. And then also things like he would need to see the diabetes nurse at his GP practice.
What advice would she be giving him?
She would ask him to attend his regular appointments, to check his feet regularly, to make sure he's wearing comfortable shoes, and check his feet regularly for blisters and things and ulcers, and maybe do things like check the temperature of the bath with a bit of his body that can feel the temperature before getting in.
What about therapeutic options? Are there any treatments you could give him?
Some people get a lot of pain with this, and I know that things like gabapentin can help the pain.
Okay, any other drugs other than gabapentin?
I guess drugs that are good for neuropathic pain, because that's the cause of it, so things like carbamazepine and things, and obviously the insulin for the diabetic control.
Do you think nerve conduction studies would be useful here?
Yes, they might help with a definite diagnosis, but I think it's important to treat the cause of it, because sometimes they can take a long time to get.
Okay then, thank you. So we'll now just move on to the next patient.
Okay.